Hello, this is Pharmacist Films, and welcome to the first episode in my drug education series. This was inspired by the lack of awesome and entertaining content about drugs and how they work. My content will be geared primarily for pharmacy students, but can definitely be used for prescribers, medical students, nurses, nursing students, or for patient education. First, I need to get a disclaimer out of the way. Disclaimer: I am not a pharmacist, yet. Information presented in this video is primarily from lecture materials used at my university, as well as from studies and resources around the internet. Okay, now that that's out of the way, let's get into some drugs. Infectious Diseases Episode 1, the Echinocandins. Probably the most important information about the echinocandins is that they are not antibiotics. They are antifungal medications. Echinocandins inhibit an enzyme called 1,3-beta-glucan synthase. In other words, they prevent the formation of beta-glucans in fungi. Well, you can either take that information at surface value,
Oh, cool. They inhibit beta-glucan synthesis. I'll just memorize that.
or some of you may ask,
Hey, Pharmacist Films, what in the heck does that mean for the fungi?
excellent question, random student. Beta-glucans are a major component of fungal cell walls. Inhibition of their synthesis means that the fungal cell wall will be susceptible to osmotic forces, and then the fungal cell will lyse, and the cell will die. Pretty cool, right?
Hey, that's pretty good.
Also, fun fact, beta-glucans are also found in the cell walls of plants used as grains, and is associated with lowering cholesterol. Ingesting about 6.5 to 6.9 grams of beta-glucan per day can reduce LDL cholesterol by up to 7%. Now, on to some drug examples. Probably the most prominent example is caspofungin, which is widely used in the hospital setting. It was approved by the FDA in 2001 primarily for invasive aspergillosis. Oh yeah, and this is what it looks like.
Check out those primary and secondary amines.
So, what exactly can this bad boy treat? It's generally very active against most Aspergillus and Candida species. However, an exception exists for Candida parapsilosis. For Candida parapsilosis, the typical first-line approach to treatment is liposomal amphotericin B, and sometimes fluconazole is used as a second-line therapy. However, studies have shown that caspofungin is just as effective as amphotericin B. It's just that caspofungin's MIC for Candida parapsilosis is higher than for other Candida species. In addition to that information, it's important to note that in the treatment of Aspergillus fumigatus with both caspofungin and amphotericin, results suggest that the two treatments do not antagonize each other. Neat! We've got our spectrum of activity put together, so where does that leave us in terms of indications? Well, caspofungin is used to treat esophageal candidiasis, candidemia, candidal intraabdominal abscesses, candidal peritonitis, candidal pleural space infections, invasive aspergillosis in patients who cannot tolerate other therapies, which include amphotericin B and itraconazole, and finally, empiric therapy of fungal infections in febrile neutropenic patients. Wait, hold on a sec here. Empiric therapy for febrile neutropenic patients? Why the heck is it approved for that? Here's the reasoning. First of all, we need to define febrile neutropenia. Typically, this is seen in immunocompromised patients, cancer, HIV, etc. They have a low neutrophil count, and they have a persistent fever, indicating that something is clearly wrong. Once a bacterial infection is ruled out, we have our answer: febrile neutropenia associated with a fungal infection. Okay, wait, hold on another sec here. Why caspofungin and not a different antifungal medication like Ambisome or an azole antifungal? Well, there are two answers to that question. With regards to Ambisome, the side effects and nephrotoxicity are enough to not use it for empiric therapy. With regards to azole antifungals, there are too many cytochrome P450 interactions with other drugs that the immunocompromised patients are likely on, so we want to avoid these as well.
Hey, Mr. Pharmacist Films person, did I just hear you correctly? We want to avoid azole antifungals because of interactions. Doesn't caspofungin have any CYP450 interactions?
Hey there, random stranger. You did indeed hear that correctly, and that leads us to the pharmacokinetics of caspofungin. Caspofungin has hepatic non-cytochrome P450 metabolism, which is great. It is metabolized slowly via hydrolysis and acetylation, giving us a half-life of around 10 hours. Some of the degraded products of caspofungin are excreted solely renally, but these are only byproducts. Trials of caspofungin on lactating rats show that the drug was found in their milk, but it is unknown whether or not it is excreted from human breast milk. Caspofungin was embryotoxic in animal studies, and no studies have been done on pregnant human women. It is a pregnancy category C drug, meaning that it should only be used in pregnant women if the potential benefit to the mother outweighs the risk to the fetus. Some frequent adverse effects associated with caspofungin include phlebitis and thrombophlebitis, which is like phlebitis, but with a blood clot added into the mix. Pretty neat, right? Another possible adverse effect is a histamine-mediated infusion-related reaction, kind of like Red Man syndrome with vancomycin. To avoid this, just slow down the infusion rate. Oh yeah, and there are some warnings and precautions and stuff like that. Nothing major except this one little thing. What was it now? Oh yeah.
Limit the concurrent use of cyclosporine.
Caspofungin commonly elevates the hepatic transaminase enzymes, AST and ALT, with concurrent use of cyclosporine. Oh, also use caution in cases of hepatic impairment since a dosage reduction is required with moderate impairment.
Check out that Child-Pugh score for liver function.
In a hospital setting, caspofungin is usually seen in 50 mg and 70 mg vials. For invasive aspergillosis or invasive candidiasis, the loading dose is usually 70 mg infused over a 1-hour period, and it is a 50 mg dose per day after that, also infused over 1 hour. Duration of treatment for these conditions varies based on the symptom resolution and cultures. For esophageal candidiasis, the dosing is 50 mg per day infused over 1 hour, and it continues for 7 to 14 days after the resolution of symptoms. However, in the case of esophageal candidiasis, if the patient's Child-Pugh score is in the range of 7 to 9, the dose is reduced to 35 mg per day. This is just an example of how hepatic insufficiency can impact the dosing of caspofungin. I should also mention that resistance to caspofungin isn't much of a problem currently, but some multi-drug resistant Candida auris were resistant to echinocandins. Okay, so we covered dosing and whatnot. What goes into the preparation of a caspofungin IV solution? Well, it is always reconstituted with sodium chloride, typically 0.9%. It is not compatible or stable in a dextrose solution. It's also not recommended to be mixed or co-infused with other agents. Once it's reconstituted, it's stable for 24 hours and it needs to be refrigerated. Hey, that's pretty cool. Okay, cool, moving on. So next up is mycofungin, which was approved by the FDA in 2005. It's very similar to caspofungin in that the mechanism of action is the same and its spectrum includes most Candida species, including Candida parapsilosis. Its indications are slightly different though. With regards to treatment, it is used for candidemia, acute disseminated candidiasis, Candida peritonitis and abscesses, and esophageal candidiasis. With regards to prophylaxis, it is used to prevent candidal infections in patients receiving bone marrow transplants. It also has an off-label use as primary antifungal prophylaxis in pediatric oncology patients, because we love saving the kids. Mycofungin has a half-life of 11 to 21 hours, and it also undergoes hepatic non-cytochrome P450 metabolism. There aren't a lot of drug interactions that alter the pharmacokinetics of mycofungin. Rifampin, tacrolimus, and cyclosporine all did not interfere, which is pretty impressive. However, patients on sirolimus or nifedipine concurrently with mycofungin need to be monitored for sirolimus or nifedipine toxicity, and their dosage of these two medications may need to be reduced if necessary. Mycofungin, like caspofungin, should not be mixed or co-infused with other drugs or else it will precipitate. Unlike caspofungin though, mycofungin can be reconstituted with either sodium chloride or dextrose diluents. Why is this? Quite frankly, I have no idea. I've scoured the web for information, but could not find why this was definitively the case. However, if I had to make an educated guess, I would say that it is because mycofungin has an oxysulfonic acid component, which you can see here at the top right corner of the molecule. This would allow for more complete dissolution in the dextrose solution, compared to the structure of caspofungin, which has a structure that includes a hydroxyl group, which is slightly less hydrophilic in the same place. That's just an assumption I'm making though. So in terms of mycofungin dosing, for acute disseminated candidiasis, abscesses, and candidal peritonitis, the dosing is 100 mg daily infused over 1 hour with a 15-day mean duration of therapy. For esophageal candidiasis, it is 150 mg daily infused over 1 hour, also with a 15-day mean duration of therapy. For those bone marrow transplant patients receiving this as prophylaxis of Candida species infections, the dosing is 50 mg daily infused over 1 hour, with no definitive duration of therapy. The last echinocandin we're going to talk about today is anidulafungin, which was approved by the FDA in 2006. The structure, as you can see, is generally more lipophilic than caspofungin and mycofungin, as it is lacking some of the hydrophilic components found in the latter two drugs. What this gives us is a drug that is insoluble in water, which means that the manufacturer gives us a neat vial of dehydrated alcohol in water to reconstitute the anidulafungin powder with. Once the anidulafungin powder is reconstituted with the dehydrated alcohol in water, it can be diluted with saline or dextrose solutions and then must be used within 24 hours. So that was anidulafungin preparation. Its spectrum includes various Candida species, including Candida parapsilosis. The mechanism of action is the exact same as caspofungin, and it is indicated for candidemia and other forms of candidal infections, such as intra-abdominal, peritoneal, and esophageal candidal infections. One unique off-label indication for anidulafungin is catheter-related bloodstream infections caused by Candida species, specifically in pediatric patients. With regards to pharmacokinetics, anidulafungin is different than the other echinocandins. This is because hepatic metabolism is not observed. There's no cytochrome P450 metabolism, and anidulafungin does not significantly inhibit the activities of other CYP enzymes. Anidulafungin actually just degrades in the plasma, and it has a half-life of 27 hours. Anidulafungin has no clinically relevant drug-drug interactions with drugs that are likely to be co-administered with it, which is also different than the other echinocandins. In terms of dosage, for candidemia and other Candida species, the dosing is a loading dose of 200 mg on the first day, followed by a 100 mg daily dose thereafter. Usually therapy with anidulafungin continues 14 days after the date of the last positive culture. With esophageal candidiasis, which is always special for some reason, there's a single 100 mg loading dose of anidulafungin on day 1, followed by 50 mg daily thereafter. Treatment is for a minimum of 14 days and for at least 7 days following resolution of symptoms. One special note, there is no dosage adjustment necessary for any degree of renal or hepatic insufficiency with anidulafungin. So if you want to skip the hassle, avoid mycofungin and caspofungin and skip straight to anidulafungin. So we've officially made it to the end of the video. I hope you enjoyed watching and learned something about the echinocandins. I'm really trying to produce content that is different and feels like it doesn't drag on, so please let me know in the comments how I did and if I should continue making these types of videos in the future, since this did take a lot of time and effort to make. Anyways, this has been a Pharmacist Films video, and I'll catch you next time.